actually. Okay. So let's talk a little bit about the exam. The average was 79. So it was definitely up from the first exam. It was up 4 points. So it's pretty good. I mean, the average was almost a B, actually, which is pretty good. I mean, impressive. It's where if you guys recall, it's what I said would happen. And then typically with the third exam, they even move up. I wouldn't anticipate they move up as much as they did between the first exam and the second exam. Maybe just a point or two, but still, having averages that are upper 70s, low 80s is actually expected with this group. I mean, usually by this point in your career, you guys choose to be here. You're not forced. There's not some counselor telling you have to take a class. If I turn you off, you're usually gone the first week or two. So you're not going to stick around for 2 exams, right? Yeah, so we're on the downward slope, believe it or not. So let's do a little housekeeping. If we pull out our syllabus, so we look at our schedule, just to get everybody on the same page. So we got a lecture today, and we don't have a post-quiz this week. We have a pre-quiz that's due next week, and it will be due Monday by noon, even though Monday's a holiday. Okay, just to remind you, there's a pre-quiz due on Monday. We don't have lecture, but you have the pre-quiz that's due Monday by noon, so we'll keep that schedule. So you have all week to get it done if you want to get it done early. There's no class Monday, it's Veterans Day, and then we'll pick up on Wednesday, and then we have a post-quiz 10 due next Friday. Nothing to say that we can't do pre and post-quiz this week, as you guys know the drill at this point. So we get through renal and liver, and then we go through respiratory for a week. Then we start cardiovascular before Thanksgiving on Monday. The Wednesday before Thanksgiving, we're not having class. Okay, so I told you this day one, so you can schedule your flights, right? Nothing's changed. And then we'll come back from Thanksgiving, and we've got 2 more lectures in cardiovascular, and we're done. Okay, so we're pretty much, well, you have a final, you take a final, anyway. But we're kind of on the homeward stretch. So any questions on the schedule? Usually after the second exam, things go like Mach 5 as far as speed. It seems like things kind of ramp up, and then they hit a stride, and then we just, cruise through the end of the semester. So, great time to do point calculations. If you're happy with your score and you saw some marked improvements from exam 1 to exam 2, then I would just keep doing what you're doing. Like, you got it dialed in. If it's still not there, then let's schedule some time to come see me. Some of you have already done that, because I'm not going to have office hours on Monday. It's Veterans Day. So some of you want to talk on Wednesday, and we can do that next Wednesday. Okay? Any questions or comments? I'm not going to hand back the Scantrons quite yet. I have a couple of students that were out of town for institutional excuses, and so I'm still doing some makeup exams. One of your colleagues was working in Hawaii, or whatever that's about, right? Had all the right documentation, but they were at a conference in Hawaii presenting. So, yeah, I mean, you're in impressive company here. You guys are the ones that are gonna be taking care of me when I'm old. It's pretty awesome. Right? So I'm encouraged. So you did really well in the exam, 79. Average is great. Again, we don't curve down. It's not like, now to get an A, you have to have 92%. It's none of that funny business. Okay? All right. You guys ready? What did the femur say to the patella? What did the femur say to the patella? I need you. Very well done. Yeah. How did the ice feel when it heard it was fire? It was crushed. All right. What do you say to Simba when he's moving too slow? Mufasa. Very well done. Okay. If you are looking for, I'm going to shamelessly pitch this for my daughter's fundraiser. If you're looking for a Christmas present for mom or dad, these scented candles, which are essential oil scented candles, will arrive before Christmas. So you can sign up. There's like 17 million options right here. Okay, so you want to order one, come see me after class, okay? And this is recorded, so Riley, there you go. I actually pitched it for you. All right, so we're in renal diseases, and then we'll finish up liver next Wednesday. So we'll have kind of like a week before we see each other again. But I want to go through some overview. We'll ask a couple of questions as we walk through the overview. So let's talk a little bit about kidney architecture to remind ourselves. So the area of the kidneys that contain the glomeruli are what? Medulla, cortex, capsule, pyramids, hollows. All right, great. Cortex has it. Well done. And we're going to look at a couple of different glomerular diseases. And these diseases that we'll look at are an overview and definitely not all-encompassing diseases, as you know. So we're just going to cover categorically glomerular disorders, renal failure, as well as infections. Again, this isn't everything that goes on with kidney, but it gives you kind of an overview and hones some of your studying on what we're going to cover in this last exam. Now, exam 3, which is called the final, and I should have stated this, so let's go over it. The final is in this classroom, but it's on Tuesday. It's not on Monday, and it's not on Wednesday. And it's at 3 o'clock to 5 o'clock. And so one thing that I'm actually grateful for is it's actually on Tuesday, because some of you might show up on Monday in this class, right, at 2:20. You're like, where is everybody? Well, the good news is you haven't missed anything yet, okay? So then you'll email me and be like, what happened to the final? And say, oh, it's tomorrow at 3. And, oh, sweet, I got a whole other day to study. So that works out well. There have been semesters where, it's on a Monday and it's like a Tuesday, Thursday class, and people show up on Tuesday and they miss the final. So that sucks. All right. So the final is in here, 3 to 5. You won't need the full time because it's going to be more like a regular exam, like exam 2. It'll take you an hour and 15 minutes, like a normal class period. Okay. Same format, same number of questions, similar style. We'll have maybe a little bit more review question material, like maybe 20, 25%, something like that. But now you guys, I think, feel pretty comfortable with no surprises. So when we walk through these topics in this class, let's first review architecturally. So the kidneys themselves receive about a third of all blood flow off the aorta. So you remember the thoracic aorta curves around the arch, comes down to the abdominal aorta, then you have the renal arteries that branch off of the abdominal aorta. And about a third of cardiac output actually goes directly into the kidneys for filtration. And so you can appreciate from this diagram, we've got our renal artery that comes into the kidney, and then the renal vein obviously brings everything back into the venous circulation. And then down at the level of the glomerulus, within the medulla, we actually have the filtration process that's taking place. So this is where you have the tuft of capillary beds, right? We've got Bowman's capsule. We have our tubular network where we're concentrating glomerular filtrate, right? Glomerular filtrate is just filtered blood that comes out of the bloodstream, and it goes into the tubular network, and then you flow it back and forth over concentration gradients. You reabsorb a lot of water, okay? You reabsorb some of the solutes you want to keep, and then you get rid of a lot of metabolic waste products. You guys remember all this? Okay. So I just want you to understand from a 30,000 foot view what this looks like and tell you if this doesn't happen, you won't live very long. And after the last lecture, well, we had an exam, so I think it was the lecture before that, one of you came up and asked about kidney dialysis. And one of your colleagues asked about kidney dialysis. And I don't know if you're reading ahead or you're thinking about it or you have a loved one, but this is why kidney dialysis is happening, is if these aren't functional and you're not filtering out these metabolites, your homeostatic balance in your system is totally off. So if renal function is decreasing, that is a bad thing, okay? If you lose a kidney, you can live with one, as long as it's healthy, but you cannot live with zero for very long. You know, kidney dialysis is usually patients will come in maybe twice a week, 3 times a week. They get connected up to a machine that basically does the function of what we just described. So blood comes out of the arm, it goes into the machine, it's run through a tubular network that has a bunch of filters. It keeps the water, it keeps some of the electrolytes, and then it removes the waste products, the metabolites. And then it puts it right back into the patient on the venous side. Okay? And then you can imagine if you do that 2 or 3 times a week, now you've worn out the blood vessel that they've punctured. And so now people will have to have dialysis access further up the arm. Then they'll implant a synthetic vessel loop so they can puncture the prosthetic vasculature instead of your main vessel. But again, this is a very big deal, okay? So I'm just kind of giving you this global perspective. Let me ask this question, because we'll get there. If blood flow to the kidney tissue, the parenchymal tissue of the kidney itself is compromised, what will happen to the kidney? What's that? An infarct. You guys follow? You starve the kidney of oxygen for it to work metabolically. It can't do all this great filtration. Okay, so a kidney infarct would be a type of necrosis known as coagulative, very well done, because the architecture of the vascular tree in the kidney is very much like it is in the heart. And so you'll get this wedge-shaped infarct. And kidney infarcts are real clinical problems. Okay, when you have atherosclerotic lesions that reduce blood flow into the kidney and the kidney is starved of oxygen, has an infarct, you get necrotic. You guys understand what's happening here? Okay. All right. So let's review some other terms from renal physiology. Bless you. Urea. Urea is the catabolism of amino acids and the catabolism of nucleic acids. So you're going to generate uric acid when you break down amino acids, and you're going to generate creatine when you break down nucleic acids. So urea is a waste product that's a byproduct, really, of catabolic processes. Azotemia. Azotemia is a measurement of nitrogen level in the blood. And it's called blood urea nitrogen, which is the term at the very bottom of this slide. And urea is going to go up and develop a condition known as azotemia when you've got an excess of protein breakdown or protein metabolism. Uremia is a definition that broadly describes diseases associated with kidneys or kidney failure or things that would lead up to kidney failure. What about this term proteinuria? Protein in the urine, okay? Proteins are small or large? Large molecules.
So if you have a filter, which is what the kidney really is, and you've got large molecules in the filtrate, in the urine, what does that tell you about the integrity of the architecture of the filter? Something's not right. There's big holes in it. Make sense? It's like a coffee filter where you've got grounds in your coffee. You're like, okay, let's switch out the filter. Okay? Like, did you just use a drip coffee analogy? Like, I don't do that. Sorry. But you know about it. You've seen it on TV. Okay. There's a term that's not on here, but let's add it. Glycosuria. Glycosuria. What do you think that one is? Glycosuria. Which specific sugar? Glucose in the urine. What patient population would you expect to see glucosuria? Okay, unmanaged. Let's add unmanaged diabetes mellitus. Very good. Very well done. Hematuria. But what particular cell type of blood? Hematuria. Red blood cells. So you'll have blood in the urine, so it'll have a bloodish color, a reddish color, because of the RBCs. Now, in contrast, pyuria, white blood cells. Okay? So you would do a urine test and you could test for white blood cells, but you wouldn't visibly be able to see unless you're like, Superman or something, Oliguria, low production of urine. So if you measure urine in a patient and the amount of urine they're manufacturing is low, you might be a little concerned. Either they're dehydrated, they're not drinking enough fluids, or their kidney function is low. Okay, glomerular filtration is not happening at the right rate. And then we talked about BUN, blood, urea, nitrogen. But just to remind us, so this is the amount of urea nitrogen in the urine, which is a breakdown byproduct of protein catabolism, or breaking down proteins. Okay. So all these terms will give you some indication of how the kidneys are functioning. And any one of these diseases that we're going to look at, we can talk specifically about some of these terms, and we'll look at some of those things. So let's move into glomerular diseases. So glomerular diseases are disorders that are going to impact or influence glomerular function. And glomerular function, again, is this early process that's taking place in order to filter the blood. So the glomerulus and Bowman's capsule are, by definition, considered the basic filtration unit of the kidney. The basic filtration unit of the kidney is the glomerulus and Bowman's capsule. And then the overall nephron, which includes that, plus all the tubular network, is considered the functional unit of the kidney. Okay, so the basic filtration unit is the glomerulus, and the functional unit is the whole nephron. And so that gives you a clue that the whole purpose of the kidney is to filter the blood and generate what we call glomerular filtration, or GFR, glomerular filtration rate. So if we've got some disease with the kidney, it's going to be very obvious, meaning that urine production is going to be compromised. Okay? So a blood sample and a urine sample will tell most physicians, PAs, and nurses a ton of information about the patient. Okay? And that's why we're always grabbing those. Many of these diseases are immunological, and so we're ready to talk about them right now. There's a reason that some of these things happen topic-wise at the end of the semester. And it looks like Keller has no rhyme or reason, according to the book chapter, on which direction we're headed, because I'm trying to organize them in a sequence to tell the story the way we tell it in this semester, not necessarily the way the textbook tells it. Okay? So we have a lot of immunological diseases that affect the kidneys. And the examples that we're going to look at are glomerular nephritis, which we've talked about initially already. We'll talk about diabetic nephropathy, which we've already alluded to. And here you get this tremendous accumulation of extracellular matrix proteins that thicken the glomerular basement membrane. And so what do you think happens with filtration when you thicken the membrane? Filtration goes down. And then we'll look at nephrosclerosis. In nephrosclerosis, we're going to start talking about that because we're trying to gear up the story in the cardiovascular section at the end of the semester when we look at atherosclerosis. All right, first up, let's talk about glomerulonephritis. So glomerulonephritis is a term that translates to inflammation of the glomerulus. And our pathogenesis could be either immunological or it could involve inflammation, but usually that's tied to some immunological dysfunction. So let's talk about this. We've got two main ways immunologically that we can have a problem with the glomerulus. So we can either have a antibody-antigen deposition, and this deposition, as you guys remember, this complex, if the complex forms, which is a type 3 hypersensitivity, and then that complex goes and gets stuck and lodged somewhere, it could happen in joints, or it could happen in the vasculature, or it could happen in the kidney. That's what we talked about. And that would be considered what we call a circulating type. Okay, that's what we had already talked about, is you've got the antigen in the antibody. So we have our antibody, and then we have a circulating antigen, and this whole complex starts to clump. And so you get a few of these, right, that clump up, and they circulate, and so they form a structure that has some size and mass to it, and then this thing actually gets circulated through the body, and if you've got a filter like what the kidney is, it's going to get trapped there. And so that would be called our circulating immunological issue associated with the kidneys. A type 3 hypersensitivity. Now, there's a second type, which is an in situ, or that word translates to in location. So this particular type we said was a type 3, and this is consistent with what we talked about previously. The other one that we could have is we could have the glomerular basement membrane, the basement membrane itself, that has some antigen expression on it because it has some surface markers like all cells in our body. And unfortunately, what ends up happening is you develop an antibody that binds to your basement membrane. So it doesn't circulate around, it actually, the complex, the antibody circulates around and it binds to your own tissue and it causes an immunological issue. So this would not be a type 3 hypersensitivity, it would be a what? It would be a type 2. Holy smokes, look out, it looks like you guys remember stuff. Okay, very well done. Make sense? So we've got two possibilities of how we can develop kidney disease. Okay? This one may have nothing to do with the kidney. This could be some other immunology that's happening in the body. You're developing these complexes in the blood, and they just get big enough that they get stuck in the filter. This one actually is a breakdown of self-antigens against some protein in the basement membrane of the glomerulus. And so this is also, obviously a type 2 hypersensitivity. Make sense? Let's look at some of these pictures, just to kind of reinforce the ideas. Okay, so here is our a portion of our glomerulus, and we're blowing up in this box. So we've got circulating type here, and we've got in situ here. And this right here, this sort of red-colored S that I've drawn in black, this is our basement membrane. And you can see in the circulating type, we've got sort of the antigen-antibody complex that's getting trapped. And it's getting trapped in clumps in certain areas and then nothing in other areas. Make sense? So this would be our circulating immunology, or a type 3 hypersensitivity, leading to glomerulonephritis. In this situation, let's look at this one first. These antibodies that are circulating, see how these little Y antibodies, right, these antibody structures are circulating freely, and the antigen that they bind to is sitting on the basement membrane. So you have the antigen-antibody complex only on the basement membrane, but nowhere else. Like the free antibodies have nothing bound to them. Okay. This is an in situ against the anti-GBM, or an anti-GBM antibody. This one is still in situ. It's kind of a blend, but it's in situ because you have the antigen being on the glomerular basement membrane, and the antibody binds, but it binds and clumps all at the same time. Okay? So really just two categories. We have circulating and we have in situ. You guys with me? So once you have these type 3 or type 2 hypersensitivity reactions, now you're going to stimulate an inflammatory cascade of events against the kidney tissue. You guys follow? All right. So we've got our antibody-antigen complexes that form. That activates complement. Now we start to recruit neutrophils, monocytes, macrophages. Right, monocytes become the macrophages. Platelets will show up as well. We'll degranulate that macrophage, right, dumping chemical signaling agents. And we'll even start depositing fibrin because of clotting activities due to those platelets. You guys remember all this? So let's look at two different pictures here. You know how I love these pictures. So we've got two different stains that are shown on this slide. One of these is a circulating reaction at the glomerulus, and the other one is an in situ reaction at the glomerulus. Okay, so one of these is circulating, one of these is in situ. So what we're looking at is a biopsy sample has been processed, an antibody has been used against the antibody-antigen reaction to highlight it. Then you use a secondary immunohistochemistry marker that has a fluorochrome attached to it. And when you hit it with a certain wavelength of light, it emits at a different wavelength of light, and that's what you're seeing. You're seeing either a green color on your left, or you see on your right kind of a yellowish color. So the question to the audience is, which one of these, and you guys can talk amongst yourself, would be considered in situ, and which one is considered circulating? And then the next question is, why do you decide that? You guys follow? Okay. Turn to your neighbor, talk it over. I want to hear your answers. Okay. We have a brave soul that wants to explain the answer and give us a rationale as to why you think that's correct. Richard?
A, in situ, because we see it bound on tissue specifically. B, in circulation, because we're seeing some of it in and around tissue.
In and around. Show me in and around.
In in tissue around tissue.
Okay, fair. What if I told you that, that's a fair comment. This one has very little background stain. This one has some background stain out here. What if I told you this was all non-specific out here? See how it's slightly lighter than what's inside here? So what if I told you that this was real stain and this is background signal, and this is all real stain with very little background signal? Okay. I told you that. Okay, but I see where you came from. Anybody else want to explain what they're seeing and justify why? Okay.
I think that A is the circulating one because those clumps of the antibody complex are kind of stuck in like that glomerulus, where they're like plugging the holes or the spaces in between the endothelial cells. Whereas
Okay.
B, you have in situ or whatever, because the antibodies are not bound yet by the time they're getting filtered, so they're getting to spread out like that basement membrane.
Okay, so I completely agree that this is not the best immunohistochemistry picture. This came out of your textbook, actually. But, you know, to Richard's point, if you don't know that this is background, but I just told you that, it might mix it up, and that's why we're going over this. If you hone in on the actual positive stain, what's actually real stain, like what was mentioned here, you see how it's punctate, meaning there's a gap right here. There's concentrated areas of highlighted antibody antigen activity, and then there's areas where it's completely dark and there's nothing there. So it looks like it's clumping. Whereas over here, it's continuous. It's as if it's interacting with everything along the basement membrane. Does that make sense? So we would characterize these two stains. A would be considered a granular stain. Granular, indicative of a circulating type 3 hypersensitivity. And then B would be what we would call linear staining, characteristic of a type 2 like hypersensitivity, where you've got continuous antibody spreading throughout the entire basement membrane, evenly, without a lot of clumping and bunching. Does that make sense? Okay, there's a reason that we're walking through this, because that is not intuitive. You look at this, you may not see that right off the bat, and I want you to appreciate the very different staining patterns between the two. Okay, well done. Oh, sorry, it's that one. All right, let's talk about 3 different types of glomerulonephritis. We're going to talk about rapid progressing, we're going to talk about acute diffuse, and then chronic. So 3 different types. Rapidly progressing or rapidly progressive is one that's often associated with patients that have systemic lupus. The thought process is there's an autoantibody to type 4 collagen. And you get this aggressive progression of glomerular disease, and you get a loss of function. So if you look at the histology on this particular slide, here's a quote-unquote normal glomerulus and the Bowman's capsule, and you see the white space, which is Bowman's space. That's a healthy-looking glomerulus. And then over here, you see a diseased example. There's 3 of them in this particular panel. Here, this one, there's still a little bit of Bowman's space, but this one particularly, what is in Bowman's space? What's that? Neutrophils. Perfect. Are they supposed to be there? What does that tell you? Inflammation, right? You guys are behaving like pathologists right now. Look out, right? You guys literally just looked at histology and evaluated it all by yourself, right? Weeks later. Kind of a little scary, right? But that's exactly right. This is, you can see that this is more broad. Here's one that's not quite as inflamed, but we've got a rapid progressing glomerulonephritis that's happening within these patients. Now, in these patients, oftentimes it's idiopathic. We don't really understand why. I told you that oftentimes it's thought to be a type 4 collagen that you're responding to. Usually this is post a flare-up in a patient that has systemic lupus. And we've got in this right image, we've got these crescent-shaped structures that are composed of proliferating epithelial cells. And so this crescent-shaped structure, these guys right here, these pink stained kind of like half-moon structures that are exaggerated compared to what you would see over in normal glomerular epithelium, is this crescent-shaped disease, which is also a pathological architectural indicator of rapid progressing glomerulonephritis. So sometimes it's called the crescent disease because of that particular feature. If we look at the second type, which we're going to refer to as acute diffuse. So a little bit of background on acute diffuse glomerulonephritis. This one, unfortunately, has a high incident rate in our pediatric population. And these are patients that oftentimes between the ages of 6 and 10 years of age. It can happen in any patient, but it's the type of glomerulonephritis that you'll see in a young patient. Usually it shows up a week to 4 weeks post-infection. And you're like, what infection are we talking about? We're talking about strep infection, like strep throat, for example. And it's streptococcal pneumonia bacteria, and in strep throat, which in our pediatric population it's very contagious and it's very rampant, and if it's not treated well and not treated completely, you can have this acute diffuse glomerulonephritis that will show up. So post strep infection could also be a staph infection, could be a viral infection that might stimulate this as well. But oftentimes it's strep. So now you have an antigen-antibody complex that forms against strep, type 3 hypersensitivity, and this complex circulates around and gets stuck in the filter, and now you've got inflammation associated with the glomerulus as a result of a post-strep infection. Okay? Type 3 hypersensitivity yet once again. So this image, you can see from the hematoxylineation stained section, and we can back up. There's not much of a Bowman space. You can see elements of neutrophil activity within that space as well. Not quite as obvious as what we saw over here, but it's definitely obvious in comparison to a normal glomerulus. All right, now the last one that we're going to talk about in the category of glomerulonephritis. This is chronic glomerulonephritis. So in chronic glomerulonephritis, as the name would infer, we're dealing with kidney disease that's over a long period of time. These are patients that have kidney problems for decades, and the kidney is compromised. They probably need to have a transplant. It is often the cause of renal failure in patients. And what you are looking at in this particular slide is a tremendous amount of scarring. And so, like what we saw in the previous two examples, we get a lot of inflammation. Well, you guys know if you take inflammation out chronically over time, you get a lot of what? Fibrotic scarring. Okay? And so, if you look at this trichrome stain, that's what this stain is. And trichrome is a really interesting stain because the blue highlights collagen. And in scar tissue, we get a lot of excess collagen being laid down to try to kind of fill in the gaps or the holes where functional tissue has been lost. And so if you remember back to our wound healing lecture, when we were talking about wound healing, we're talking about scarring on the skin, and I was alluding to, hey, we're going to look at other types of scarring in other organs later in the semester. And so here's a perfect example, and we'll see it again next Wednesday when we talk about liver, because we'll see the same kind of similar histology with liver, cirrhotic liver, or fibrotic liver disease. But here we're talking about scarred kidneys. And so here is a quote-unquote normal glomerulus, and what do you think these blue tufts are? Scarred glomeruli. They're basically dead glomeruli that collagen has been laid down, and that's the scar that you and I see on our skin, and we can appreciate, ooh, that wound healing wasn't so great. Well, the same thing happens in internal organs, but most people don't really get a chance to look at it like this. Okay? So we've got necrotic lesions because we had damage to the kidney. What could have caused the chronic glomerulonephritis? Well, it could be there was vascular disease to the kidney. We lost blood flow. We get an infarct, and now 10 years later, that infarcted tissue has compromised kidney function, and we've got chronic glomerulonephritis. And in the area of the infarct, if you look, you've got 6 out of 7 glomeruli that are dead, and kidney function is compromised because you're not filtering the blood. If you were to look grossly, if you were to rub your hand over the surface of this kidney that had chronic glomerulonephritis, it would feel bumpy, right? So it's hard to appreciate, but there's this sort of cobblestone appearance where you, instead of having a smooth organ, it would actually be bumpy because of all of the scarring and pitting that's happened over the years. Question?
Yeah, so post-cardiac infarct, scarring is a big topic of discussion, and so just out of curiosity, with a kidney, if it were to have an infarction, is scarring another deal where it's talked about quite a bit, and there's like a percentage that, or is it not so much?
No, it is, absolutely. I think your question is, when we talk about myocardial infarcts with the heart, we're asking about the extent of the scarring. Do they have the same kind of conversations with the kidney? Yes, absolutely. I want to know how much of the kidney function is compromised because of the infarct that took place. So, do you guys remember when I was talking about endovascular procedures where you put a wire in and then you fish the wire up under fluorescent or X-ray fluoroscopy, and you can find areas where you want to put the wire and you put a device over the wire and you put a stent in, or you open it up, you put a graft. If you don't know what you're doing, you can actually dislodge plaque lesions. And so the number one way that kidney infarcts happen is during endovascular procedures. You get a thrombus that gets dislodged and it ends up going into the kidneys. And it blocks off kidney flow. Does that make sense? Yeah, whoops. Yeah, they say other things too when that happens, other than whoops. But yeah, that would be the G-rated version of it. Yeah. So, absolutely. If a patient has a kidney infarct, the next question is how extent or how big is the infarct? How much kidney function has been lost? And then if we back up, let's just back up to here. If you've got disease of that renal artery, you can stent that. You can actually open that up. If you have vascular disease, kind of out, we're a little bit ahead of the game, but let's say this is you're looking down the tube, and let's say that you've got a lesion that's here, right? And so now your lumen looks something like this, right? So you've got, let's say, 55% block. They can open this up by stenting it. Does that make sense? But the concern is if you break any of these plaque lesions off and they go downstream into the filter and you cause a kidney infarct, now what happens to kidney function? So these are kind of the things that you will have to decide as you're treating your patients. I just get to pretend. You actually have to do it. Yeah.
How do you fix that? If you get that problem, is there anything you
How
can
do
do?
you blame the resident? Oh my gosh. I don't know. Yeah. It depends on where you are. So a lot of times it's evaluating the extent of the lesion to determine what the risk of the plaque is from rupturing. So they'll use covered stents, or they could put in filters that are downstream. So now there are cool, we do this a lot with neurovascular treatments where they're coming into the carotids, they'll put a wire through, they put a filter on the end of the wire, and they do all their instrumentation right upstream. So anything that gets broken off here gets caught by this umbrella-looking filter. Then they collapse the filter and pull it out, kind of like you collapse your umbrella, and then they pull that out. So there are companies that make these endovascular filters that are pretty cool, right? So, you know, these things, you know, they're on a wire, you know, and then it accordions out like this, right? It catches all this debris, and then it collapses down like this, just like an umbrella, and then you pull it out like that, and you've caught all of, you know, the garbage in the filter. I know, there's a lot of really cool things out there. So, chronic glomerulonephritis, right? Long-term disease. Usually there was an infarct, and now you're looking at the disease a decade or two later to see what happened. Let's say the infarct took out, you know, 75% of the kidney. That patient's probably going to lose that kidney at some point in the future. The other thing that happens if you have bilateral renal disease, oftentimes they'll stent one side, recover you, see how it goes, then stent the other side some other time later, so that you don't run the risk of losing both kidneys in one procedure, right? Which of these are normally found in urine? Water, ions like potassium, sodium, bicarbonate, creatine, urea, protein, all but B, all but E. All but E. Obviously, there's not G on the Scantron, so I can't ask a question like this. All right. If you have a patient, let's say they had a procedure, let's say it was your colleague, it's his fault or her fault, and you're seeing that patient 10 years later, that chronic glomerulonephritis, what do you think their symptoms are? Manifestations. What are they struggling with? So go ahead and let's create a list. Write them down. And then use those words that, if you want, use those words that we introduced the lecture with.
Or they're talking about in general. They have glomerulonephritis. Well, if they have already stepping out,
All right, let's hear a couple of examples. Clinical manifestations for these patients. Polydipsia. Okay, so excessive thirst. Why excessive thirst? Osmolarities off. Okay. So if they're losing functionality of the filter, they're losing a lot of solutes. I would agree. Okay, polyuria, or polydipsia, excuse me. Probably not polyuria. It's probably the opposite, right? What's that? Oliguria, low urine production. What else? If the filter is compromised, what are some of the things you might see in the urine? Protein? Proteinuria, yeah. Brianna? You're going to say that? Okay. He took your answer. What else? What else are you going to see? Hematuria, RBCs, have blood in the urine. What about white blood cells? Would you see those? Yeah, probably too. You probably also see white blood cells. What's that one? What's that? Pyuria. Very good. These patients, we didn't really talk about this, but think about this. If the fluid that you have in your bloodstream isn't filtering well and you're making less urine, where's that fluid going to go? Huh? Who said it? Edema. Who said edema? Very well done. It's going to go out into the tissue, so now the patient's going to have tissue edema. Right? It's got to go somewhere. So if you're not releasing it in the urine, you're going to have fluid accumulation. We'll talk about edema. We'll talk about the kidneys again when we talk about heart failure. So hold that idea, because it's coming in a couple of weeks. Okay? All right. Very well done. All right, let's shift over to nephrosclerosis. This is a term that's talking about scarring of the tubules. And this is often found in unmanaged diabetics. It's often found in patients that have hypertension or high blood pressure. And it's because these vessels are under pressure or under stress, and they're remodeling. They're responding to that. In this particular slide, you've got two arterioles that are shown right here in the main part of the hematoxylin eosin stage section. And you can see a narrowed lumen, that white hole, and you can see an exaggerated thickening of the wall, which has excessive hyaline cartilage deposition. So the wall is remodeling with hyaline cartilage to try to reinforce the wall because it's under extra pressure. So it thickens the wall. Okay. So morphologically, this hyaline arterial sclerosis that's taking place is a thickening of the walls of these vessels that are found within the kidney itself. Now, these patients, as you would expect, proteinuria, although many times they're asymptomatic. They don't know they have a lot of protein in the urine. You just do a urinalysis. They've got generalized and focal ischemia of the kidneys, and they have a decrease in serum protein because they're losing a lot of it in the urine. All right. Last little section is renal failure, but let's talk about which structure, in which structure does reabsorption first occur? Glomerulus, proximal convoluted tubule, nephron loop, distal convoluted tubule, or the collecting duct? Proximal. Okay, it's the first one. You get reabsorption the whole way through, but that's the first one. All right, so let's talk about renal failure. In renal failure, acute renal failure, we have a rapid and a severe decline in urine production. We've got compromised glomerular filtration, and there's really three areas or places where we can get problems. We get problems before the kidney. We get problems at the level of the kidney, or the kidney itself, that's the parenchymal tissue. Or thirdly, it could be after it leaves the kidney, meaning some sort of obstruction. So if you look at this diagram, we've got blood flow. Here's our renal vessels that come in. So we can have a pre-renal problem where we've got blockage, like we talked about. We could actually have something happening at the level of the kidney, like toxin buildup, or we could have inflammation, or direct attack of the kidney, like the basement membrane, where we're talking about acute hypersensitivity. Or we could have something that's happening after it leaves. We could have like a urinary tract infection. We could have a kidney stone that gets stuck there. We could have a tumor or a lesion that puts pressure on the ureters and restricts flow leaving the kidney. There's direct damage that could occur from trauma anywhere post-kidney. There could be prostate cancer in males, where you're putting extra pressure and blocking flow out of the bladder. Okay, so renal failure as a broad category could happen before the kidney, like in the situation of vascular disease, something at the kidney itself, like with our type 2 hypersensitivities or even our type 3 hypersensitivities, or it could be some sort of problem after the urine is supposed to leave the kidney. Any one of these areas leads to this renal failure. So let's talk about some of these etiological agents like infection, okay? We'll talk more about pyelonephritis here in a second. Secondly, we could have acute tubular necrosis. So this is a situation where, let's take our event here, where we got blood flow that's blocking. And now the parenchymal tissue of the kidney is not getting perfused. And the nephron itself, the nephron tubules are like the last structure that receives oxygen because they're the furthest away from the blood supply. So if you cut off blood supply, the nephron gets starved pretty quickly. Does that make sense? So you can have ischemic problems at the level of the nephron where you're not getting blood flow to it, and now you get an infarct or necrosis. You can have toxins. There are things that are kidney toxins. So actually, another one, just as a heads up, if you're having an endoscopic procedure or an endovascular procedure, is more accurate, and it's under fluoroscopic guidance, they put you on a table and they use x-ray, they put wires in and they inject what I call a radiopaque dye. That radiopaque dye, they monitor how much volume they inject into the patient very carefully, because the barium sulfate that is radiopaque is actually toxic to the kidney. And so you will actually lose kidneys if you overdose just so that you can see what you're doing. So they're paying attention very carefully to how much of that barium sulfate they're injecting into the patient. So that would be an example of a toxin. Or there could be, events that take place that are disturbing blood flow or trauma, right? Kidney trauma, a car accident, and the kidney gets impacted. So let's look at this diagram here. It's starting out with ischemia. So that's our general category that we've reduced blood flow to the nephron or to the kidney. And so now let's look to see what happens as we walk through the flow diagram on ischemia. Well, we've got endothelial dysfunction because endothelial cells need blood flow. And so now these guys actually respond by triggering this renin-angiotensin system and lowering the ability for urine production to take place. We've got tubular cell injury that takes place because the tubules themselves need oxygen. If it's reversible, that's great. You can actually kind of bring it back, but it may be irreversible and you either lead to necrosis or apoptosis. But even in the case of reversible injury, meaning that it's not past that point where you can rescue the cells, you start to see what ends up happening where we've got an increase in tubuloglomerular feedback and an increase in intratubular pressure. These two items, as well as the vasoconstriction that happens with endothelium, produces a reduction in urine production or a decrease in GFR, oliguria. So, in all of these events associated with acute renal failure, ultimately urine production goes away. You're not making any urine. And now you're not filtering the blood. And that's a huge problem for patients, not to filter. You'll get toxic levels of metabolites that will build up, and other systems will start shutting down, like the brain. Right? The brain is a very critical functioning organ where it has high tolerances, tight tolerances on what kind of metabolites it can handle. Okay, now thirdly, we could have a patient that goes into shock. So for example, if you have a complete reduction in blood flow, let's say it's a car accident and the aorta is severed, and now blood flow basically goes to zero, the kidney's not going to get any blood flow at all immediately. And so trauma that decreases blood flow, and you get no urine production. And in our trauma patients, when there's severe blood loss, right? You guys do, ED medicine, stabilize the patient, right? They'll look at multiple organ injuries. They'll take care of the critical organs first, and it's usually in this order. It's usually brain, heart, then what? Kidneys. Yep. So, stabilize the brain, heart's going well, okay? They'll put you on a respirator and worry about lungs after they really kind of focus on, so how long do we think blood flow stopped? Patient had a heart attack, patient was hit by a car, lost a severe amount of blood. Say, what's brain status? What's the heart looking like? Next organ is, what do the kidneys look like? Okay? So they're number 3 in order of critical. All right, what is shock? Reduced ability of the body to return to homeostasis, severe reduced delivery of blood to tissues, getting zapped, and you stick your finger in a wall outlet, hyperperfusion of the lungs, or your last grade. I don't think it was your last grade because you guys did pretty well, but what is it? The severe reduced delivery of blood to tissues. Okay, finally, let's talk about infections. So if we back up to this diagram, we're here, post-renal. And I want to talk with you about what's happening down here post-renally that could cause problems ultimately with the kidney. Okay? Infections. So one of the most common infections in this whole system are urinary tract infections, UTIs. More common in females than in males because the urethra in females is shorter. Okay? It's closer to the GI tract or the anus, and so there's a bigger opportunity for bacterial flora to enter into the urinary tract in females. Okay? Pretty common in young girls, because they're, especially when they're potty training, because they're trying to learn how to do the whole process, right? Right front to back instead of the other direction. So UTIs can be a big problem. They're one of the most common post-renal issues that you will probably deal with. What we have overall are the common agents. We've got Enterobacteria, Proteus, or E. coli, and there's an ascending infection where bacteria colonizes up the urinary tract and into the bladder. And typically, this is actually very uncomfortable, okay? Painful, irritating, hurts when the patient urinates. There was a great movie. I can't remember if it was a kidney stone or if it was a UTI, but it was Tom Hanks in I think it's called The Green Mile. Anybody see that movie? Was it a kidney stone? Okay. He's trying to pass a kidney stone, but that actor portrayal is almost what, especially men, because we're wimps, look like when they have UTIs. Okay, it's like passing a kidney stone. Okay, so that's a good movie. Kind of weird that I just recommended a movie based on watching Tom Hanks go to the bathroom. But he's a great actor. Sells it. You're like, oh, I don't want that. That doesn't look good. So bacterial colonization, if this ends up working its way up retrograde, the problem that you have is you could actually have an infection of the kidney itself. And past the bladder, the patients don't typically feel this because there's not a lot of nerve endings. What ends up happening when the bladder gets infected and starts working its way back is the patient gets really sick because now the bacterial infection is starting to go more systemic. So they'll run a fever, a systemic fever. Okay? And this actually happened to one of our daughters. She didn't complain. She has a high pain tolerance, had a UTI that we didn't know about, and ended up getting a kidney infection, retrograde, and was running a fever of 109. Yeah. And my wife and I were supposed to go on a trip overseas on a vacation, and she wasn't feeling well, was running a fever. We kept giving her, Tylenol and ibuprofen, and, just watching her. And finally we made the call, like, I don't think we should don't think, oh, no, it wasn't, it was Coronado, San Diego. And we were supposed to meet some people there, we canceled our trip, they went, we stayed back, and she was admitted to the hospital. It's like, well, that was a good parent moment. We've had a lot of bad ones, but I want to brag about that one because it was a really good parent moment. So we canceled our trip, and sure enough, she had 109. The pediatrician took her temperature and was like, oh my gosh, and then did like a rectal temperature. She was really little, okay, probably 3 years of age, and had just learned how, it's just potty trained, just learned how to do everything on her own. Had to make some adjustments. And they admitted her to the ICU that same moment. Like, we just literally went from the pediatrician's office over to FMC. So, big deal. Kidney's fine. Antibiotics took care of it, but this is an ascending infection. Okay? There is this process that we're going to talk about with pyelonephritis. So this is a urinary tract infection term, an ascending urinary tract infection term. And we'll talk about it a little bit more here in a second. Reflex nephropathy. So in all patients, there's some little level of retrograde flow of the urine after urination is done. Okay? And so depending upon the individual of how much retrograde muscle contraction there is, you may have a more aggressive sort of backwash, if you will. And that's where the bacteria can get back up into the urinary tract. Okay? And it's just dependent, variable from patient to patient. And so some of these contributing factors, and we'll talk about this in a second on a different slide, is there's this VUR reflux is what it's called, vesicular reflux, where it kind of brings everything retrograde. But let's talk about descending before we go to pyelonephritis and these other conditions. So descending or hematogenous. So this would be coming from this direction rather than from this direction. So in this, you could have a staph infection in the bloodstream. And because the kidneys are what? A filter, where does the staph infection end up? In the kidney, okay? Or it could be an E. coli infection in the blood. And it ends up in the kidney, and now you've got a descending or a bloodborne hematogenous infection that's coming from a bacteremia that's happening, circulating throughout the bloodstream. So you will have to do some sleuthing to determine if there's kidney problems, which direction did it come from. Does that make sense? Okay. All right, so let's talk about pyelonephritis. Bacterial-caused inflammation of the kidney. We got the renal pelvis involved, we got parenchymal tissue or the functional tissue of the kidney, and even the renal calyces. Our contributing factor of a ascending urinary tract infection or pyelonephritis, that's what this is. Pyelonephritis is the fancy term for a UTI. Is gender. So I told you females are more at risk of developing this than males. Prostate fluid or prostatic fluid in males has a slight antimicrobial or antibiotic activity to it. And so the urethra in males tends to be less susceptible to infection because of prostatic fluid that coats it. There could be, so this VUR, in some patients, this reflux is a little bit more aggressive. If there's a urinary tract obstruction, right, with kidney stones, they might be more at risk of developing a UTI or pyelonephritis. Diabetes itself, because why? You got a lot of sugar in the urine, and bacteria like sugar, okay? And then congenital abnormalities. There are definitely some congenital abnormalities that you might run into where you're going to have patients that have a much more aggressive opportunity for UTIs to form. Okay, so reflex nephropathy. Again, this is this VUR reflux where you get this retrograde muscle contraction that takes place. In its extreme form, you get repetitive UTIs. It makes it all the way ascending as a pyelonephrotic activity up to the kidney, and then you get trauma or damage where you've got scarring that's happening at the level of the kidney, and of course, that can lead to renal complications, or even in extreme cases, renal failure. All right? So, in summary, we highlighted a couple of things like glomerular disorders. We ended up going down this pathway of where things go aggressively, all the way to renal failure. And we even talked about infections that can happen retrograde or ascending, or from the blood, hematogenous, as a descending infection. So, no assignments for the rest of the week, okay? You have Monday off from lecture, but you do have a pre-quiz due on Monday at noon, and I'll see you guys next Wednesday.